Hello, everyone, and welcome to the Association of California Nurse Leaders webinar, Building and Sustaining Healthy Work Environments for Nurse Leaders. My name is Brenda Brozak, and I'm ACNL's Communication and Education Consultant, and I'll be providing technical support and co-facilitating the webinar with Pat McFarland. And right now, it's my pleasure to introduce Patricia McFarland, who's CEO of ACNL. Many of you know that Pat's been with ACNL for many years, actually for over 20 years. Before joining ACNL, Pat also held a variety of leadership and clinical roles for Dignity Health Hospitals in Sacramento. And I've worked with Pat for over 9 years, and Pat is a visionary leader who has really worked so hard to advance ACNL's mission and work in so many ways. And I've really learned so much from Pat over the years, and I continue to learn from her every day. So now, without further ado, let me turn the webinar over to Pat. Hello, Pat.
Hi, Brenda, and thank you very much for that intro. And I think our learning always is on a two-way street. It's been my pleasure to work with you. And for those of you that don't know, Brenda's been with us as a consultant for, like she said, about 9 years now, first as our ED and now as a consultant. And she's the one that really helps us with these webinars, which is critical to helping us carry our mission throughout the state. And people can listen to these webinars anytime throughout the year. Last year, really kicked off a number of webinars, and the webinar we're going to hear today is about the healthy work environment and the work that is so critical for all of us as nurse leaders to really get behind. In fact, at the Strategic Planning Committee this year, under our new president's direction, Bev Quay, we have decided to reinstitute our Healthy Work Environment Committee, and I'm so pleased to say our speaker today, Nancy Blake, is taking that on. So look forward to some great work from the members of ACNL as we really deal with this difficult issue. But how great it is for us that we have one of the leading experts in the country here in California. And it's our good friend, longtime member of ACNL, Dr. Nancy Blake, who is with Children's Hospital of LA. She is the director of their critical care services, and just an all-around great leader. She's had active roles in the Critical Care Nursing Association, held roles at the national level as well as the state level, been president of her local group down there in Los Angeles, but really has become a leader in the healthy work environment area. And if you Google her, you'll see she has written a number of articles on this topic, so I'm sure you'll want to read those articles after we have her conference today. I was very pleased to hear that Nancy was inducted to the American Academy of Nursing in 2013, and over the course of the last, I think it may be 4 or 5 years now, Nancy has been a voice on the CHA Medication Safety Committee, which is really critical. And when we started talking about medication safety, we didn't have to look very far because we knew Nancy should be an appointee to that committee, and CHA agrees. So without further ado, let me tell you that I'm very honored that Nancy is presenting for us today. And Nancy, thank you for sharing your time and your expertise and really for making a difference for our profession and all the work you do. So Nancy, take it away.
Well, welcome. This is obviously something that I'm very passionate about, and a topic that I chose to do my doctoral dissertation around because I think it's very important. And I think sometimes people think communication, collaboration, and leadership are soft skills, and I think it's important that we have really strong work environments for our staff today because it's obviously a very difficult work environment for people to be in, and we want to make sure problems are taken care of. Before we get
Nancy,
started,
this is Brenda. You wanted to see who was in the audience with us, and so we have our polling question here. So if all of you in our audience can let us know what your role is, and people are answering, I have the poll visible so that everyone can see. We have several folks at the director level. We have a couple of nurse executives, manager supervisor. We have a couple in the other category. But anyway, as everyone's chiming in, it looks like we have quite a variety of folks on our webinar today. Nancy?
Great. So I'm going to go ahead and move to the objectives. I also want to say I'm not going to discuss what's happening in academia, but I do know Dory Fontaine at University of Virginia has done a couple of publications, and this has become a problem in academia also. So if you know of anybody that's looking for information on healthy work environments in academia, you can look to University of Virginia. So our objectives for today are to list 3 reasons why healthy work environments are important in healthcare today, articulate 3 steps to building healthy work environments on a unit, and describe the importance of a nurse leader role in maintaining a healthy work environment. I speak all over the country, and I have talked to staff nurses who really are working hard, but if their nurse leader doesn't agree that there's a problem, they have difficulty. So I'm very happy to see that we have a lot of managers, directors, and nurse execs. One of the reasons I think it's important is I think for a while there people thought the nursing shortage was over. If you look at the data and you look at Peter Burhouse et al. Article in 2009, he was talking about the fact that estimated between now and 2025 there's going to be a shortage of 260,000 registered nurses. Because if you read the article, many of the boomers are retiring, and a lot of them will be out of the workforce. You also look at some of the information from the labor statistics. There are going to be additional positions. And then you look at some of the things with the Affordable Care Act, we have additional positions, we're going to need nurses. So it really is something that we need to make sure our work environments are healthy and that we're not driving people away from nursing, and we're keeping them in the organization, because it also, I'll talk about, you can save money. Definitions of healthy work environment, I'm going to give you a couple from some people who have published on this topic for years. I call Joanne Dish the mother of healthy work environments, and I told her that myself, because she was one of the first people to publish on this, and her definition is really looking at a healthy work environment as a work setting in which policies, procedures, and systems are designed so employees are able to meet organizational objectives and achieve personal satisfaction in their environment. A lot of the magnet work was driven around, what are the magnetized hospitals and the work units that people are happy at. Also, Kramer and Schmallenberg have done a lot of research on it and talk about an area where the nurse is able to care, to be productive and give quality care, and it's a satisfying workplace where personal needs can be met. Also, Maria Shirey has done a lot of leadership on authentic leadership, a lot of articles on that, and she's talked about a supportive, where the whole human being, patient-focused, and a joyful workplace. And then last, Griff Alsbach has done some publishing on the same topic and talks about organizational practice that focus on being the employer of choice, and really informal interactions and professional status. So it really does go nicely hand in hand with the magnet, where you look at structures and process and you have good outcomes, both from nurse retention and patient outcomes. So really it started in 2004. There was a coalition of major nursing organizations that published 9 key elements of a healthy work environment. And they're listed on the slide. I'm not going to go through each and every one of them, but from that alliance, AACN looked at their healthy work environment standards and basically focused on 6 of them. And I'm going to discuss AACN standards just briefly, because these are probably the ones that are referred to more often than the ones from the Nursing Alliance. AACN looks at optimal patient outcomes, clinical excellence, and then healthy work environments, and has the 6 standards listed in here. And basically, I was on the board of directors when AACN rolled these out, and we were hearing from our members that unhealthy work environments contribute to medical errors. If people are afraid to ask questions of the senior staff, then they're doing things on their own and potentially putting the patient at risk. Or if there's a physician that somebody's afraid to call in the middle of the night, then that patient is not getting the care that they need. So it's important that the work environments are healthy and that people have good communication. And ineffective care delivery and conflict amongst health professionals. We can all think about a topic or a time when you saw major conflict in health professionals that got in the way of patient care. Negative, demoralizing, and unsafe conditions can't continue. And a healthy work environment is imperative to ensure patient safety, enhance staff recruitment and retention, and maintain hospitals' financial viability. And I'll talk about some of the costs that in some of the consultations I've done that have been incurred because a hospital had a poor work environment. So the standards, there are 6 standards that ACN developed, and it's skilled communication, true collaboration, effective decision-making, appropriate staffing, meaningful recognition, and authentic leadership. And I'll go through each one of them. But some of these, because of Magnet, the effective decision-making and collaborative governance, it's getting better. And meaningful recognition with the DAISY Award and a lot of the awards that are being offered nowadays, it's getting better. But some of the rest are not getting better. So skilled communication, nurses must be as proficient in communication skills as they are in their clinical skills. That was when we had the rolling out of the Healthy Work Environment Standards. Dennis O'Leary was the president of Joint Commission, and he basically said this was a bold move because we always gave people kudos for their clinical skills, but we know those people who have excellent clinical skills but poor communication skills. And those are the clinical experts that we want people to be able to talk to. Each one of the standards has critical elements. I'll just go through the one with skilled communication, but it really does say healthcare organizations need to provide team members with access to programs to develop critical communication skills. And some hospitals, when money gets tight, they cut out the organizational development, or they cut out some of the consultation that I think is really important to help people communicate appropriately. Skilled communicators focused on finding solutions, and skilled communicators invite and hear all relevant perspectives. So skilled communicators are also skilled listeners. True collaboration, nurses must be relentless in pursuing and fostering collaboration, and that's really important to make sure that collaboration is key and that the team is working well together. Effective decision-making, that nurses need to be valued and committed partners in making policy and directing and evaluating clinical care and leading organizational operations. And like I said, this has gotten better with collaborative governance in hospitals. Appropriate staffing. Staffing must ensure the effective match between patient needs and nurse competencies, that it's not all about a numerical value, but you may have a family that is end of life and the family needs a lot of support. And if you went strictly by ratios, you wouldn't be able to have that effective match with that family, and making sure that the nurse is comfortable sitting with somebody that's at end of life. So it's making sure that you not only have the right staff, but the staff with the right competencies for that family need at the time. Meaningful recognition, that nurses must be recognized and must recognize others for the value each brings to the work of the organization. I always say we need to show value to each member of the team, that in the NICU, when I'm talking about feeding and helping patients with their suck reflex, I bring in the occupational therapy. So it's the entire team that needs to be recognized. And then authentic leadership. I think that this is really very important, because if you don't have authentic leadership, if the leader doesn't believe there's a problem, the staff on the unit, no matter how good they are going to struggle in improving their work environment. And that nurse leaders must fully embrace the imperative of a healthy work environment, authentically live it, and engage others in its achievement. And that's really walking the talk, or modeling the way of Kouzes and Posner. It's really important that the leader model the way. So what we know is poor communication and intimidating behavior create a culture of silence and disrupt patient care. Unhealthy work environments and poor communication contribute to medical errors, and I'll talk a little bit about some Joint Commission look at 10 years of sentinel events, but ineffective care delivery and conflict amongst healthcare professionals. And when I talk to students, I say, think about an area that you were a student where it was an unhealthy work environment, and everybody can give examples of what they've seen, where the team doesn't communicate well together, or there's not a good, effective teamwork. And then Joint Commission stated that communication failures, they looked at sentinel events from 1995 to 2005, and they published it in 2007. But 70% of their sentinel events, the primary root cause was communication. They also looked at where it was a secondary cause, and 100% of the sentinel events had some problem with communication. And then, like I said, Kramer Schmallenberg has done a lot of research on this, but nurse manager support really impacts nurse productivity, recruitment, retention, and job satisfaction. And when the environment feels safe, staff can communicate freely, and in those environments, turnover is low. They often say people don't leave their hospital, they leave their manager. And when they feel like they have open, honest communication and there's an open door policy, and if they bring up an issue, they see a change, people really feel like they are in an environment that they're supported and there's trust. The cost of replacing a nurse is approximately $100,000. I've seen the last thing that was actually published was probably in 1992, and it said $65,000. But if you really look at the training that we do, especially the residency programs, and some are 6-month training, it's really a high cost that organizations are putting into training and replacing a nurse. Team communication collaboration is critical in resuscitation. And if you look at the literature, there's numerous research that supports poor outcomes in patients with poor team communication. And I'll talk about my research at UCLA, my doctoral dissertation research. And then one of the recommendations of the first IOM report was to improve collaboration. So it's been there. There's been surveys that have been done, and we've got that information. This is basically the Joint Commission. If you look at their 10 years of sentinel events, communication is actually number 1. And then orientation, training, patient assessment, staffing, all the way down to organizational culture. But I believe healthy work environment, organizational culture plays a key, because it really is the leader sets the tone. So to tell you a little bit about my research, I looked at the influence of the work environment on PEDS ICU, patient outcomes, and nurses' intent to leave. I completed my dissertation and defended in 2012. But I did research over 2 years and looked at 10 pediatric intensive care units in large children's hospitals, and I'll talk about my sample in just a minute. But I wanted to show some data on how the work environment, specifically looking at leadership, communication, and collaboration, impacted patient outcomes and also impacted retention. So I'll talk a little bit about my aims and my results. The first aim was to look at the relationship between communication, collaboration, and leadership, and central line bloodstream infections and ventilator-associated pneumonias. That was really, those were outcome data. In those 10 units, I could get the data at the same time that I did the questionnaire of the nurses. The second one was to look at the association between communication, collaboration, and leadership and risk-adjusted mortality. Because it was risk-adjusted, so you might have a patient that goes into the ICU that has is a bad trauma patient and a patient that's an overnight observation for surgery, and with the tool that they use, it risk-adjusts for their acuity on time of admission. And then the third aim was to establish a relationship between communication, collaboration, and leadership, and risk-adjusted length of stay in the PEDS ICU. Because if you can decrease the length of stay, obviously the organization can save money. And then the last one was to look at the relationship between the 3 variables and nurses' intent to leave their job in the next 6 months. Because I found in my review of the literature that the highest correlation to turnover was nurses saying they intend to leave their job. So those were my 4 aims. I already talked about my setting, but I looked at a cross-sectional descriptive correlational design. I used settings that were greater than 10 beds that also had pediatric critical care fellowships, so I could control for the physician coverage and the types of units. So I wasn't looking at an academic medical center against a community hospital. And then I needed 35 participants from each one of the hospitals, and I ended up getting 415 that completed the entire survey, and that I had data for those units. So I actually got more than I actually needed. The inclusion criteria was RNs in the study units that had been in the unit greater than 6 months, because I felt like somebody who'd been in the unit 6 months knew the culture of the unit and could speak to the leadership, communication, collaboration. I excluded non-RNs, and I excluded somebody who'd been there less than 6 months, but I also excluded the managers because there were questions about the leaders in the unit. The instrument I used 2 instruments. One was the Practice Environment Survey of the Nurse Work Index, which is Lake Survey, which is used very often. It's an NDNQI instrument that people use for their nurse satisfaction survey. It's widely used. And it has 31 instruments, but there were 2 domains that it measures at the unit level, leadership and collaboration. So that's where I got the results of leadership and collaboration. And then I used an instrument that was out of Berkeley, Dr. Shortell. It was an ICU nurse-physician communication. I used 22 questions to measure communication, and it really did discuss communication RN to RN and RN to MD in those 5 categories. And some of the questions, like timeliness, was the doctor tells me about changes in orders in a timely manner. They were very straightforward questions. So, summary of findings. The correlations and regression modeling was what I used, and there was a statistically significant inverse relationship with central line bloodstream infections and collaboration, communication accuracy, communication openness, and communication timeliness, which meant the better the nurses rated their communication and collaboration, the lower their central line bloodstream infections. And it meant that if somebody was walking in the room and going to touch the patient, the nurse felt comfortable saying, "Doctor, did you wash your hands before you touched that patient?" So there was some literature that I found that if people felt comfortable approaching, that there was no problem, and the outcomes were actually better. And then there was not a predictable lower incidence of ventilator-associated pneumonias, but in my review of the literature, it also showed that the only thing that decreases ventilator-associated pneumonias was a good bundle. So that wasn't a finding that I found that was any different than what I found in the literature. For AIMS 2 and 3, there was an inverse relationship with length of stay and collaboration communication, as well as risk-adjusted outcomes. And that meant the better they said the communication collaboration was in the unit, the lower the length of stay and the lower the bad outcomes. I also found an incidental finding that I was able to explain that magnet designation was associated with a higher central line infection, ventilator-associated pneumonias, and length of stay. But it was because 2 of the units that had better outcomes were on the magnet journey. And since that time, there's been a lot of research on how hard hospitals are working when they're on the magnet journey. So it was slight, it wasn't high statistically significant, but there was a little bit better outcomes in the units that were on the magnet journey. So I was able to explain that difference. It made me a little nervous when I first found it, when I did my statistics, but that was a finding that was explained. And then the last is there wasn't a statistically significant relationship between nurses' intent to leave and communication or collaboration. It was close, but it wasn't statistically significant. But there was a really high statistical significant inverse relationship. The higher they rank their leader, the lower they intend to leave. And this was very significant, and this has been published in Nursing Administration Quarterly. But it just shows that good leaders will have good retention. So really the implication of my findings was there's a correlation between good communication and decreased length of stay and risk-adjusted outcomes and central line infections. And there's a correlation between good collaboration and positive patient outcomes as above. And a strong relationship that with leadership, good leadership reduces turnover and increases retention. So I think it's really important, and that's why I'm really glad to be able to do this to an association of nurse leaders, because I do find staff nurses, I've heard some really sad stories about staff nurses at different hospitals throughout the country. And then there's, ACN has done some research on good outcomes in healthy work environments, Schmallenberg, and I already talked about Shiree. So getting to your next question, do you believe your work environment is a healthy one?
And Nancy, while people are completing this poll, I just want to remind all of you that if you have questions, go ahead and use that Q&A button and box to send your questions to us, and we will ask those of Nancy at the end of the webinar. So it looks like we have so far about a third of the folks, well, it's getting a little closer. 58% are saying yes, 37% are saying no, and we've got a small percentage saying they're not sure if their work environment is a healthy one.
And I have to say these responses mirror what I see across the country. So, so the big question is, I'll go ahead and move on, is people always ask me, where do you start? There's not a magic bullet. There's not a magic pill we can give everyone. And so you really need to figure out how to start the process. And what excites me about being the chair of the Work Environment Committee is I think people are looking for guidance on things they can do on their unit to make things better. So first really is to survey the staff. And I suggest SurveyMonkey only because it's confidential. And I think sometimes staff don't speak up because they're concerned that if they speak up and somebody knows that they said X, that there will be ramifications. And I've heard of people saying, you know, I've talked to my manager and I've told her I'm very concerned about the work environment, and then all of a sudden my vacation gets canceled. So there are people who feel like there's ramifications when they try and improve their work environment. ACN has a healthy work environment assessment tool. The only problem with that is it lumps nurses, physicians, administrators together. And if you really want to know where your problems are, you have to separate out those questions. But you can just do a survey and ask open-ended questions, or you can ask very straightforward questions. Or you can take the Healthy Work Environment Assessment Tool and break those topics into 4 different questions. And then once you have the results, many times they will divide into the 6 categories that I talked about with the different standards. And what I've done on units is really develop committees to work on the units and have the committees chaired by staff, but make sure there's a leadership person in the room. Because what you don't want to do is if there's a problem with communication and the committee on communication says we bring in Vital Smarts to do that, and you don't have the thousands of dollars to pay for a consultant, then it will be shot down. So you want to make sure leadership is there so they can talk about some realistic expectations or really do that look on investment. Charge each group with coming up with recommendations, and I have to say staff really have some simple things that don't cost a whole lot of money. And groups should first report out their recommendations to leadership before presenting to the staff. So if there are issues that the unit can't implement based on hospital policy, based on cost, you're not presenting something to the staff that they get disappointed. So some of the things others have done, and like I said, I've consulted on many units with this, and I also do review beacon applications for ACN, so I see a lot of really good suggestions that people have done, is really for skilled communication, identify communication that's not acceptable. Everyone needs to own that we're not going to gossip anymore, and you have to speak about that openly, and that you say that everyone needs to look inside themselves to see what they're doing to contribute to an healthy work environment. And on a couple of the units I've done, even the physicians want to sign a card because they feel like if they sign their name to a piece of paper that they've owned it. And nurses sometimes say, well, so-and-so's a gossip. And I said, if everyone says we're not supposed to do that and walks away, they're not going to continue to talk to themselves. And then identify that all staff need to commit to stopping the behavior. One unit actually brought a psychiatrist in to talk about bullying before bullying was really published in the literature, and when people did a self-assessment and found out that the behavior that they were supporting was bullying behavior, people don't want to be called a bully. And they don't see it. They see themselves as being passionate about what they do and passionate about their patients. And I say most people don't know that how they come across. And they don't get up in the morning to say, I'm going to go in and make everybody's life miserable today at work. Have a positive communication board where you actually do give kudos to people, and really make sure that the MDs are part of that contract. Because if you have MDs who are abusive in a unit and the hospital allows that to happen, which Joint Commission has a leadership standard for that, then it's really difficult to make sure that everything's okay. But what I've done in units is spoken to the physicians about what it will mean for them if the work environment improves. They can have a full unit, they can make their income based on being able to admit as many patients as they need, and patient outcomes will be better. And then really look at exercises on trust and effective communication. Simulation and communication is something new that has worked out very well for some hospitals, to actually have simulation of how to deal with a staff member that's coming at you with an abusive tone, and really giving people some things to say so they can practice it. Teach staff how to give and receive feedback. Feedback is not a bad thing. I always tell people as a leader, if I'm doing the wrong thing and you don't tell me, I'm going to continue to do the wrong thing with good intent. So feedback has to be encouraged, and it has to not only be seen as a negative thing, but when you're doing something right, you give positive feedback. And then one unit had 2 questions at report. And one of them is there anything you need from me, and please give me feedback on something I did well. Many times it's the night shift is all the newer nurses, the day shift is the more seasoned nurses, and sometimes people give criticisms on at change of shift, so people are afraid to give report. But actually having somebody say something positive really helped one unit get over that intense intimidation at time of change of shift, and really eliminate negative comments that happen. True collaboration. A lot of units have implemented interdisciplinary rounds where the nurses present the patients and make recommendations to the plan of care. And it really does. People have to be prepared. But nurses can say things like, they've been doing labs for the last 4 days, they've been normal, do we really need to do them every day? But really make recommendations for the plan of care. And then making sure senior staff know how to mentor staff on projects versus being negative to them. So senior staff are seen as a good thing and somebody that the new staff can learn from. And then all disciplines appreciating what the other brings to the team. That full team is what makes, I know in my area, the ICU, really a good, effective team. Effective decision-making, really having task forces led by staff, with leadership supporting, leadership participating, and helping, especially the chair of that committee, really do the work. But let the staff lead, and I think a lot of new managers are afraid that it will be seen that as a deficiency of theirs if they let the staff lead. But I think it's really important to allow the staff leadership at the bedside related to their care and their unit. And then the other thing I've seen, and I recommend it, is town hall meetings. I think a lot of times staff meetings are a lot of information giving from management. There's a lot of things that need to be shared. But to have town hall meetings where it's staff's opportunity to make suggestions and leaders listen. And we've had some pretty successful town hall meetings here with the leadership together. I know in our NICU we did some town hall meetings last year, and we brought in the physician leaders, the nurse leaders, and the respiratory leaders, because those are the teams that work closely together. And the staff saw that as very positive because they actually made suggestions, and some of the things we were able to implement. So they knew that it was kind of that cause and effect. They brought up some issues, and we were able to listen to what they had to say and roll those things out. Appropriate staffing, manage admissions and surgery schedule around the staffing for the unit. I know a lot of places say they just keep bringing patients in, bringing patients in, bringing patients in, but sometimes you have to manage it and make sure that you have the right staff. Utilizing an acuity tool, obviously that's a state mandate for us, as well as ratios, but making sure that you're staffing based on the acuity of the patients and not just a numerical value that doesn't change when the patient's acuity changes. And then last-minute changes to the surgery schedule will only occur if staffing permits. So when you add something on, if you need to take something off and reschedule that for another time in order to manage staffing. And then last, meaningful recognition. I know people always say, and Bonnie Barnes says this all the time, when they give the Daisy Award, people say, well, I was just doing what I always do, and it was my job. And people need to be recognized. And even though people do get embarrassed, public appreciation for a job well done is really important, and it goes a long way. And then identifying when a specific patient situation code or emergency went well, and staff is able to avoid a bad patient outcome because the nurse caught that in advance. And then last is authentic leadership. 360-degree feedback for managers and staff, making sure staff can give feedback to managers' evaluations, annual staff satisfaction surveys with action plans to address the problem and making sure that staff are involved in those action plans. A goal set annually for the leadership team around retention and staff satisfaction where they have control over that. Obviously, you can't have control if somebody's moving out of the state, but making sure that staff satisfaction is at a good level. And then leadership, including medical leadership, to go through initial leadership training and ongoing coaching for effectiveness. You know, I think it's important that the full team has some leadership training or at least understands their leadership style and that they're held accountable for what goes on in the unit. So some of the unit results, and I always say to get people's attention, if you went into a CEO's office and said, I can save you $1 million a year if you do a few things that maybe cost $5,000, nobody's going to argue that point. So I always suggest, and I'm trying to put together a tool that you do a return on investment. You look at the cost you're paying for agency, the incremental cost between agency and staff. You're looking at the cost for turnover and positions that are unfilled. You're looking at beds that you can't fill because you don't have staff. And you're looking at staff satisfaction and productivity. So these are some things that you can improve, but you can actually put a dollar value to it. Because, you know, and one unit we looked at the incremental cost for agency, we looked at the number of closed beds that they weren't getting income on, and we looked at the agency cost and the recruitment cost because they had 10 staff that were leaving every year. Even if you take $65,000, 10 staff leaving every year, that's costing an organization $650,000. So I always say you want to look at it as a return on investment when you do this work. And that unit that they saved $1 million per year, we probably spent $2,500 in incentives, in leadership training, and in the communication board and thank you notes. So it really was a small cost for a large return on investment. And I always say it's not a one and done. You can't do it and then walk away and say, okay, we've done our job. You really have to look at collaborative governance and making sure staff have a say in their unit. You have to look at an open door policy and making sure you leave the lines of communication open. Maintain staffing levels at a manageable level. The manager must be authentic and model the way. You can't have two different ways of behaving, one that the manager, and I think a lot of times managers need to understand that if they're supportive and they say good morning and they deal with the issues that are going on with their staff, it goes a long way. Collaboration must be standard of care on the unit, and really developing some ongoing form of meaningful recognition that's meaningful to the unit. We had one unit where they did a board, and it was the same two people that were nominating each other every months. So they took the board down because they felt like people weren't nominating. So it really wasn't worthwhile, and people were laughing because it was the same 2 people for a good 6 months that were being nominated. Some other structures that I really think are becoming very important nowadays are really looking at programs in place to deal with violence in the workplace. Every day you hear about something different, and hospitals are really, if you look at the statistics on the NIOSH website, which is National Institute of Occupational Safety and Health, hospitals are number 1 on some years, or number 2 on other years, but they're only number 2 behind those 7-Elevens and those kind of places about violence that occurs in the workplace. We also have to get a handle on that, and I'll talk a little bit about that in a minute. Safe patient handling, we obviously have a state law. Fatigue management, making sure that we're not forcing people to work overtime or begging people to work beyond the shifts that they normally have. The fatigue management literature is really saying that beyond 10 hours is really a problem, but definitely beyond 12 hours. And then moral distress. There's a lot of problems with moral distress on units, with decisions that families have made and end-of-life care and things that happen that nurses have to deal with that we forget about, that those things build up when they deal with it over and over and over again. And then leadership development programs to develop new leaders. And I know ACNL has good leadership development programs, but spending the money to make sure new leaders have a good, solid foundation, because a lot of people are promoted because of their clinical skills. And then culture training in the workplace. So an example of violence in the workplace program, and this is something that they're beginning in our organization, is really looking at the abuse, both physical and verbal, from our customers and their patients and families. And sometimes we understand that they're under significant stress, and we'll let things go. But when that happens over and over again, and that's how people behave outside of the hospital, we need to make sure that we don't allow for continued violence on the staff, and that we manage that and set the limits on our patients and families. One example is that the unit here, it's a social worker brought it from Primary Children's, and it's been replicated in a unit in California, is to really look at how you set standards, and if there's a problem and it continues to happen, that you document it. So you know you have a contract with the family that says what's okay and what's crossed the line. And our staff really need to know that security is called when somebody gets hit or there's threats. And unfortunately, sometimes we have to call the police. But we really don't want to do that because we want to be customer service because we're hospitals, but there are people who are abusive outside the hospital, and we can't let that continue. So a question for all of you: have you been a victim of workplace violence in the last 12 months?
Okay, and as everyone is completing the poll, again, let me remind you that you can send in your questions for Nancy. We're getting to the near the end of the webinar, and we'll be asking her those questions. And Nancy, it looks like we have about 20% of folks who have said yes.
Right. So 5 people have been a victim. And if you do this for staff nurses, it's a higher number. But, you know, the fact that people, 20% say they've been victims of workplace violence means we have some work to do. So OSHA defines it as an act or threat of physical violence, harassment, intimidation, or other threatening, disruptive behaviors that occur at a work site. And it ranges from threats and verbal abuse to physical assault and even homicide, and can affect and involve employees, clients, customers, and visitors. Our EDs are incredibly overcrowded, and there's a lot of problems. So we're seeing a higher threat of workplace violence here in the ED. And some other behaviors that are exhibited with workplace violence is verbal abusing and intimidating of staff, screaming or inappropriate language directed at staff, intimidation tactics, stalking or following outside the hospital, and that has happened. Not following hospital rules and policies, sexual harassment, lack of respect of diversity, race, religion, gender, or sexuality. So this is pretty widespread, and here's some of the examples. So this is the example of in our hospital where they've actually done this, and really explaining to staff, and sometimes we do have to call a code gray if there's violent or threatening behavior, and if staff are an imminent threat. Code gray, I think, is the statewide. It came out of Hospital Council of Southern California, but I think this is a recommended code across the state. If behavior continues, we need to notify management. A lot of staff think, oh, you know, we're just going to let it go. Nobody's going to do anything about it. But sometimes we have to put a contract together with our patients and families and hold them accountable for their behavior. And really, if they continue to show violent behavior, you may need to remove them from the building. There's hospitals that have restraining orders against family members, but we do need to make sure our staff is safe. And we need to not wait until things are so serious that staff or patients are harmed. But we also need to be supportive of families in crisis, but we can't allow the staff to be left in unsafe condition. So important points for leaders are really, they're key in building and sustaining healthy work environments on their unit. And if the manager's not supportive, others will not be successful. Teamwork's important, and managers and staff need to have open dialogue on topics. Sometimes we have to not take things personally when people give us feedback and understand it's a systemic issue on the unit. It's not all about us. And retention's high when staff feel supportive. And unit leaders have healthy work environments, have better outcomes, and that's really showed in my dissertation research. So why is it important to have healthy work environments? There's a direct link between work environment and patient safety. If you're not addressing your work environment, you're not addressing patient safety and staff safety. Communication is huge. It's a major component of our work environment, and we need to make sure that people know how to appropriately communicate, and that as leaders, we hold people accountable when they don't communicate. And I always tell leaders, if you don't do something about it, that is seen as an action. It's not inaction by not addressing it. The staff see that you're allowing it to happen, so it's really a problem. And then leaders need to address the issues, like I said, to hold staff accountable. So that being said, I've left a few minutes for questions. And I think
that was excellent, Nancy. Very informative. And yes, remember everyone to go ahead and send in your questions. You know, while we're doing that, I'm going to put your contact information up on the screen, and while we have our question and answer period. So Nancy has shared her contact information if anyone has any further questions, and that's also on your handouts as well.
I also have tried to, I am the section editor for the Healthy Workplace ACN Advanced Journal, so I've also tried to put some tangible examples in that, so you can find some examples that different units have done it. I've also published a lot of those articles to explain some tangible things hospitals can do. So feel free to look up my name or to look up that journal in that section. If you have good examples, let me know, because I do speak on this all over the country.
Excellent. Well, we do have a question that came in, Nancy. Can you give some specific suggestions on what to say when you see a staff member being disrespectful to one of their coworkers?
I can tell you what I've done, and I've actually asked the individual, I pulled them aside and said, can I give you some feedback? And I always tell them off the record because I obviously have a formal leadership position. And I'll explain to them what I've observed and tell them, you know, what I observed. And frequently people will say, no, that's not how I meant it. That's not what I meant to do. But I will share with them, you know, what I observed. And I also do encourage people to ask for feedback of their peers or to go back and talk to that individual and say, what I meant to say was, how did you see it? Because I could usually see the look on someone's face but really explaining what you observed and really not being afraid to give feedback. I always suggest people use iMessages, and I give this lecture on communications to the residents, new RN residents, and I say, you know, if you go home feeling bad because somebody said something, to go back the next day and say, you know, yesterday at the end of the day, you said this, this, and this. I felt very uncomfortable. Can we talk about that? And really use how you felt if you were the target. And people come back to me and say it usually does work.
Yes, and as you said earlier, that a lot of times people don't really realize how they're coming across to others. But what about those, and fortunately the number is usually small, but what about those folks who really aren't willing to change their behavior or don't want to improve their communication skills?
Then I think at that point it's up to the manager to give them feedback. And manage that either in their performance evaluation or, if they have to, through a disciplinary process, because the people that don't see it as a problem and don't see the need for change, it's up to the manager on that unit to help them. And I have to say, I have helped a couple of people who really did not understand, and one of them took that bullying survey. And I think 11 out of 14 were a bully, and she was 14 out of 14. She came to my office crying because she always told me I was crazy and that, you know, she was just holding the bar at a high level and that I was allowing people to put patients at risk whenever, because the manner in which she did it was so abrasive. And I said, you're smart, you're a clinical expert, but nobody wants to come and ask you questions. And I said, that's a shame because I can learn a lot from you.
Yes, well, that's great that she realized and can change that behavior. We have another question that came in as well. We are seeing increasing verbal abuse by inpatients on our med-surg unit. Do you have any strategies to address this?
I think what I have seen, and I saw it, we were a sponsor and covered the medical coverage at the Special Olympics this year in LA. And there was a code of conduct in each one of the venues as you went in on behavior. And I think, you know, people are trying to address how you, in your patient information, that you address behavior that is appropriate and behavior that's inappropriate, and that you follow up on that. So in your information materials, when you're orienting families, patients and families to the unit, that you talk about what's appropriate and what's inappropriate. So I think it's really setting the standard in advance and calling it out on abusive language will not be tolerated. If you have a problem, you know, that you've got a patient representative you can speak to, but really making sure people understand that it's not okay to abuse the staff.
And Nancy, do you have a template, or could you refer our participants to someplace where they might find that so that they can implement something like that in their facility?
You know what? I have, I think I have a picture on my phone of what we took at the Special Olympics, but I know I have, and it really was well done, and but I will send that to you, Brenda or Pat, so you can share. But I do have the template that they had at the Special Olympics, which was very well done.
Well, that's excellent, because we'll just add that to our post-webinar handouts that we send out.
Okay.
Yeah, and like I always say, it's easier to edit than to start with the draft. Or say, have a good example, it's something they can generate, and it's not so painful. They sit there with a blank piece of paper. So thank you for that, Nancy. I had another question that came up, if I may. You referred to the DAISY Foundation several times in your talk, and now that link is on the ACNL website. But if you'd take a minute or two to just talk about how one might connect with DAISY and the great things they're doing. Thanks.
Sure. The DAISY Foundation was developed by Mark and Bonnie Barnes, and I think it's daisy.org, DAISY, and it stands for, help me out, it's idiopathic thrombocytopenia is what their son had, Mark's son had, and he died. But they realized after their son died that they really wanted to recognize nurses for the work that they did, that they offered more than just the care that they needed to offer, but they offered full support for the family. So Mark and Bonnie Barnes, who are out of Glen Ellen, California, great people, started the DAISY Foundation to really recognize nurses for what they do. And hospitals, and now academia also has a DAISY award, can pay us, it's a small fee, to be part of the DAISY Awards and give recognition to staff for a job well done. So those that go above and beyond, and staff nominate, families nominate. Many of the hospitals have informational materials that explain what the award is, and the nurses get recognized either monthly at the hospital or quarterly with an award, and they get a lovely statue that was carved by the Shona tribe, and they get daisies. And then one thing that Patrick, their son, said, make sure, Dad, when you get Cinnabons, you get enough for the nurses because I know they like to eat. So the areas where there's a Cinnabon in the neighborhood, they also get Cinnabons for the unit to celebrate. And where they don't have a Cinnabon in the neighborhood, the nurse executive gets the ingredients to make cinnamon rolls. But it's really a nice award, and it actually, people really like being recognized for a job well done. But that is a neat recognition award.
And I've heard I know a few nurses that have been recognized, and I always think of our friend Katie Bray, who passed from this world way too soon. She always said the highest honor she ever received was the recognition from her peers, and that's where the recognition starts for the DAISY Awards, and I think that's what makes them so special, and that they live on, and it's something the nurses from hospitals that are participating in this can strive to get recognized. So thank you for that, Nancy.
And I just want to remind everybody that up on your screen is our webinar evaluation. As we continue, if you have any more questions to send in, I just want to make sure you can just take that evaluation right on the screen, click on it, and, this really helps us plan future webinars.
And I appreciate your time. If you have any other questions, you've got my contact information. Like I said, I've done a lot of work, and a lot of people have shared a lot of really good stories. And I think that the things that are recommended, that I put a lot of the information in my slides, don't cost a whole lot of money. And it has really been a positive thing to see units turn things around for very little money, but really getting the units to understand what a healthy work environment is and what it's not, and making sure that those individuals that don't see themselves as being toxic to the work environment understand how things that they say and how they say them are seen as abusive from other people.
Yep. I think that you've summarized it beautifully for us, Nancy. And Brenda, if there's no more questions for this afternoon, let me just be the first to thank Nancy for a great presentation and for the work you've done, because when we have an environment where it's conducive to working, it does reflect and helps us to give better patient care. People arrive on the unit charged and ready to go and to address the needs and make that connection with their patients. So this is really important work, and that's why ACNL has invested this year in really looking at opportunities to spread and to help nurse leaders change the environment, and if it is unhealthy, and if they have healthy work environments, let's brag about it and share it with the others. So Nancy, you've given us some great work, some great tools, and I just want to thank you for your time and your expertise, and I look forward to working with you over the next year or so as we really start to hone in and bring ACNL's voice to this work. So Brenda, were there any more questions?
There are no more questions, and as we bring the webinar to a close, I'd like to chime in also and say, Nancy, thank you so much for this really excellent information. I think healthy work environments are a passion and concern from a lot of us. So really great information, and I want to thank all of our participants for joining us today, and to remind you that the webinar is recorded, and we will send you that recording within a week. So thank you very much. Nancy, any closing thoughts you'd like to share?
No, I thank you very much, and I look forward to working with you and hopefully creating some tools for the leaders that are members to take back to their hospital.
Excellent.
Okay.
Thank you
well,
very much.
thank you, everyone. We'll keep the evaluation on the screen for the next 10, 15 minutes, but our webinar is now officially closed. So, again, thank you for participating today.